like to welcome everybody to the lecture tonight, to the OETT lecture. And we're really excited to have our guest speaker, Professor Ramstrand from Sweden, who'll be joining us. And the Professor Ramstrand will be introduced by Mr. Duncan Ferguson from the Orthotic Education and Training Trust. And we're very happy to collaborate with Jönköping University and the British Association of Prosthetists and Orthotists to bring this to you today. So what I'll do is hand over to Mr. Ferguson, and we can go from there. So thank you, Duncan.
Thank you, Sandy. I'd just like to open up by giving our grateful thanks to BAPO for facilitating this first webinar, which is unique to OETT. And we're absolutely delighted that Professor Ramstrand has agreed to give this keynote lecture. Professor Nerrolyn Ramstrand was educated as a prosthetist orthotist at La Trobe University and obtained her doctoral degree from the same institution. After completing her doctorate, Nerrolyn spent 3 years working within the Prosthetics and Orthotics program at the British Columbia Institute of Technology in Vancouver, in Canada, before beginning her career at Jönköping University in Sweden. She currently divides her time between the School of Health and Welfare, where she is a full professor of prosthetics and orthotics, the President's Office at Jönköping University, where she serves as the President's Advisor for Internationalization. Nerrolyn currently heads 3 large research projects related to prosthetics and orthotics. Thank you. So welcome, Professor Ramstrand. The floor is yours.
Thank you very much, Duncan. Let me just try and share my screen and get everything sorted at this end so we have the right view. Thank you so much for the invitation and to BAPO for inviting me to present one of my favorite topics today. Sandy and Duncan, feel free to interrupt me if something goes awry in the views here, but I hope everyone sees the full screen view of the presentation. This is a topic that's very dear to me. It's something that we've been working on in Jönköping for about, I think it's nearly 8 years since we started with this work. So I'm really excited to present it to you and hopefully present some new ideas and get some of your ideas on how cognitive load could be of interest in clinical prosthetics and orthotics, and maybe what we should be doing next when we're designing future research projects. So first I want to welcome you to Sweden for the evening. We say Jönköping, you can see on the map there, is in southern Sweden. The Swedes call it mid-Sweden, but mostly because nobody goes to the top of Sweden because it's too cold. So we tend to call it the middle of Sweden, but it's a really beautiful city on 2 lakes there. And you can see on the presentation here, this is the university from above, or part of the university. It actually takes up a large part of the city here. You can see it's shaped like a key. This building is our School of Business, and we have the School of Engineering, which is shaped like a key of knowledge.
We've got a little problem seeing the slides just now. I was wondering if you could pop them on and off again. Thank you.
Let's thank you, Sandy. Let's end it and try it all again.
Oh, that's perfect now. I can see your screen now, so thank you.
Okay, but do you see the full, you don't see the full slideshow, Sandy?
No, can just see the outline view. Yes, that's it now. Thank you.
It's working. And if I change slides?
Perfect.
Great. Because this is really where I want to start. And I'm starting here because it's something that piqued my interest, and one of the main reasons that I started to look at cognitive load. I belong to a research group. As you can imagine, as a researcher within prosthetics and orthotics, it's rather difficult to find mentors and peers to work with, to find research or to develop research proposals and projects. And a lot of the time you end up in a research group with other professionals. And I ended up in a research group called Child in Jönköping, which really focuses on children with children in need of special support, we could say. So it's often educators, but also health professionals. And the common language that we use, and one of the themes that we use for our research in that group, is really the ICF structure. So, and I think this is probably nothing new to anyone on the webinar this evening, but we talk about health conditions in terms of body structures and functions and what people are able to do, and activities and participation. And I got rather interested in the ICF concept or framework. I'm not sure, some people argue if we call it a model, so I'll call it a framework. Because I started to think about, okay, as a clinical prosthetist, orthotist, what do we look at and what are we good at? Certainly in terms of research in prosthetics and orthotics, I think we're really good at measuring body structures and functions. I think clinically we also focus a terrible lot on body structures and functions. I don't think that's odd at all. I also think we're reasonably good at focusing on activity. Sorry, I'll just jump over here. So in terms of body structures and functions, we look at contractures, we look at muscle strength, we look at balance. We've certainly looked at all of these things in the research that we do in prosthetics and orthotics. In terms of activity, if we're looking at ICF framework, we measure gait performance, or we evaluate gait performance, even with just observational gait analysis. We look at ADLs, and we look at things like energetics when people are performing certain activities. Where I think we fall down is in the participation domain of ICF. And I like to think that prosthetic and orthotic devices have a profound influence on all of these domains of the ICF. I think showing the benefit for body structure and function is easy. I think showing benefit for activity is relatively easy, but I think we've been quite poor at demonstrating benefits in terms of participation. And when I think about it, it's not odd, it's not easy to measure participation. I think there are professional groups that we work with, occupational therapists in particular, that are very good at measuring participation. As a prosthetist orthotist myself, then I also wonder, what is my role here? Should my role be to measure participation? As a researcher, I think it's very important for me to demonstrate the full breadth of what prosthetic and orthotic devices can contribute to a person's life situation. So participation was something that interested me, and something that we talked a lot about in our research group when we talked about research with children. So what's participation? If we look at the definitions within the ICF, so the International Classification of Functioning, its definition is being there and being engaged, which I think is really interesting. So you physically have to be somewhere in order to participate. My son has to be at the football match in order to participate in it. The question is what he's doing while he is there. I can measure if he's there or not. That's easy to measure. The next part of participation, being engaged, is much more difficult to measure, because he could be standing in the middle of the football field, which he often does, and staring at the stars rather than looking at what's going on in the game. So he's not engaged in the game. So in order to participate in an activity, we need both of these things. We need to physically be present, but we also need to be able to engage in what it is, what the activity is. So this requires allocation of attention. And my colleagues that do this type of work on participation in children, particularly children with disabilities in classroom settings, they measure attention in a number of different ways. So they have a proxy measure, which means that they ask either the parents or the teacher, is the child engaged in the activity? Or they observe. So they have a framework, which is a list of things to look for when a child is in a playground, for example, and they tick off, if I'm watching this particular child, what are they doing that might reflect or demonstrate that they are engaged in an activity? But you know yourselves, you can be staring at the Zoom screen right now, but your brain can be completely somewhere else. So it can look like you're engaged in the activity, but you're not. So I started to think about, okay, well, how can we measure this, and how might it be of interest within prosthetics and orthotics, and it's about allocation of attention. Where is my attention, and how much attentional demand does an activity take to perform? And that's where we start talking physiologically about what's happening in the brain. And in the brain, when we talk about attention, or that we need to think about something a lot when we're performing an activity, physiologically we would call it cognitive load. So there is increased activity in a part of the brain, and what we perceive that as being, so the individual would describe that as being effort. So we talk about effort and attention a lot in this type of literature. Absolutely nothing new. The first model, or one of the most popular models of attention, came out in the 70s. There's a fellow called David Kahneman has written a terrible lot about attention. There are many, many models that to try and describe how you allocate attention, how much attention something might take, what happens when you don't have enough attentional capacity. But most of these models are really based on Kahneman's basic principle here. And what he is suggesting is that you have an available capacity to attend to a task. So you think about your brain, you have a sort of a volume of a capacity that you can use to allocate to a task. You have to decide then what you're going to allocate your attention towards. And there's lots of different elements that can influence that. There are some elements like how fatigued you are, how stressed you are, that we know can affect attentional capacity. But somewhere you're going to have to make a decision of what to attend to. Based upon that, you do something and there's a response. The problem, of course, comes when you exceed that attentional capacity. And I think this is a really nice, easy way to think about attentional capacity. So I always think about it as a big glass of water, or a big glass that you can fill up. And if you perform a task that doesn't require much attentional demand, like the top right corner here, I'm not sure if you see my screen there, but if you have a task that doesn't take much attentional capacity, that means you can perform other things at the same time. So you could walk and talk. But if you fill up that glass, if your attentional capacity is at its maximum, then something has to give. You have to choose what you're going to attend to. This may be subconsciously. So we can use gait as an example. Here's a fellow with no known issues that may affect his gait. So walking down a flat street, level surface, no risks in the way. The attentional demand for walking, we know that there is some. So it's not zero. It's not an automated task like some people may suggest. There is a little bit of attentional demand required, but it's minimal, which means that when you then want to do other things like walk and talk with someone at the same time, walk and type an SMS on your telephone, walk and look out for traffic, hold your child's hand and as they're falling or trying to cross a road or trying to run out in front of something, it means that we don't exceed our attentional capacity. What then becomes a very interesting question, I think, when we think about attention in these ways is, do people with physical impairments need to allocate more attention in order to perform their activities of daily living or any sort of desired activity? And then from a prosthetic and orthotic perspective, it can get even more interesting, because then we can say, well, if this is the case, then can an assistive device, whether that be a prosthesis, orthosis, or something else, can that influence cognitive load? So can we use prosthetic and orthotic devices to minimize or to decrease the attentional demand an activity requires, and in doing so, free up some attentional capacity for that individual to be able to do other things, walk and talk, walk and look out for obstacles so that they don't fall. I mentioned that attentional demand is something that becomes physiological, or cognitive load is something that's physiological. And I don't need to explain sort of neuroanatomy to anyone in this room, I'm sure. But what we do know is that the frontal cortex of the brain, and in particular the dorsolateral prefrontal cortex, is the area of the brain that becomes most active when we see an increase in attentional demand. So we're talking about attention only here. You could also potentially measure sort of motor activities and different things, but what I'm particularly interested in is this concept of attention. And we see increased activity in the brain in this dorsolateral prefrontal cortex area of the brain when that is the case. So my idea was, how do we measure this? We know that people measure it indirectly. In the clinical setting, people will often use a dual task paradigm, and many of you may be using that clinically. When you're doing a dynamic alignment of a prosthesis, you can ask your patient to walk on a level surface without any hazards. Then you can give them a secondary task, a dual task. Count backwards in threes from 170 while you're walking and see what happens, because then you're increasing the attentional demand of the task. And if they reach capacity, something's going to give. What do they choose to focus on? And oftentimes it will be, well, safety first. They have to focus on walking, and the secondary task may need to be compromised. So how do we measure this? There's been lots of progress in the neuroimaging area. Previously, in order to measure activity in the brain, we would have had to do a MRI or some type of imaging technique that requires the patient to remain still, which doesn't really help us when we want to measure activity in dynamic situations. But nowadays we have two options. So we have EEG, which measures electrical activity in the brain, or the technique that I use, which is called functional near-infrared spectroscopy. So this is the equipment I use. So basically you can see on the picture to the right here, the lady with all of the probes fitted onto the cap. There are two different types of probes in this cap, one that emits infrared light and the other that absorbs it. So we have a signal that emits light and a signal that picks up the light that's bounced back. And so what we know is that when we shine infrared light into the skin, then it's absorbed by oxygenated and deoxygenated hemoglobin. So we can measure how much light is bouncing back and how much is absorbed. And there's a formula that we can then use to look at relative changes in the hemoglobin concentration in the brain. So essentially we can see through a formula by measuring blood flow in the brain, how much activity there is in certain areas of the brain. And we can model that. So depending upon where I put these probes on the brain, I can model activity dynamically in the brain. And the fantastic thing about this is that it's relatively easy to put on. Generally, I could probably put this on someone in 15 minutes with explanations. It's relatively stable, so it can be used. I throw a sort of a tablet in a backpack and that the person wears. If I'm doing something dynamic, I know in the next couple of weeks we're doing a project with elderly drivers and looking at what it is they find difficult. So I just sit in the back seat while the driver wears this. But I can have it in a backpack, and our prosthetic and orthotic users can walk with this on their head, and we can measure all sorts of dynamic activities and model what's going on in the brain. So let's start looking at some of the research that our team has been doing over the last sort of 8 years or so. And we start with a question fairly simply by asking the question, do people with physical impairments need to allocate more attention to perform ADLs or not? So we can compare a group with impairments to a group who do not have impairments. And we can demonstrate this on transfemoral prosthesis users, and this is one of the papers that one of my doctoral students published in 2000. And what we did here is we had 16 controls who were individuals who had no physical issues. We had transfemoral prosthesis users. We had a group of 14 who had non-microprocessor controlled knees and a group who had microprocessor controlled knees. Now, always tricky when you start to do research with microprocessor controlled knees. It gets very expensive. The idea of randomizing groups would have been very nice, but not practical. So we tried to get groups that were relatively similar in age. You can see the distribution between males and females here. They were active prosthesis users, so most of them were either trauma or tumors. The time since amputation was very long, so there were established prosthesis users. We're not talking about the controls here, of course. There was no difference between our non-microprocessor controlled and our microprocessor control group. That's important here in these particular parameters. Prosthetic use scores were also relatively similar. But the question here, I think that the first question we're going to ask and I'm going to present is just, is there a difference between prosthesis users and able-bodied controls? So we fit electrodes or probes to these individuals, and we measured brain activity in the frontal and motor cortex, but we're mostly interested in the dorsolateral prefrontal cortex. We measured temporospatial data. It would have been nice to measure them in the gait lab as well, but it was a bit impractical. We had to travel all over the place to get so many patients. But we collected temporospatial data, number of steps and time to walk 10 meters. And then we also asked them at the end to do a 6-minute walk test, just to look at functional capacity to see if there was a difference between our groups. So here's the result. And what you see on the left here is a picture that represents a comparison between our healthy controls and all of the prosthesis users. This analysis technique is called statistical parametric mapping. Essentially, all we have to know here is that a comparison's been made. The areas that are red demonstrate a significant difference in average in cortical brain activity between the healthy controls and the people with a prosthesis. When we use this technique, we have a baseline measurement of brain activity. It's a little bit like measuring muscle activity, and we look at relative differences in brain activity. So here we can see that there is a significant difference between the groups, and I can tell you that the individuals walking with a prosthesis is what you see in red here. So they had significantly higher brain activity in those areas that are red and orange. As compared to the areas that are green and yellow is no difference. We also saw differences in time in 10-meter walk tests, in number of steps taken, and 6-minute walk test. I don't think anyone would be surprised at all by those results. What is interesting, though, is that we can very clearly show that our prosthesis users require more cortical or require more attentional demand. So they're thinking more when they walk. And I think this is also what we hear from qualitative data, that patients say that they have to think when they walk, or if they have to talk or something, they have to stop walking because they can't do two things at once and it's challenging. Or they fall when this sort of attentional capacity gets exceeded, when it's difficult. They don't like to walk in groups. They'll walk behind so that they can focus on going up a ramp rather than having to talk to their friends. And I want to link this back to this idea of participation, because this idea that our patients or clients need to have a higher cognitive load when they perform activities means that they're missing out on this participation element. They're there, but they're engaged in an activity other than that they want to be engaged in. They want to engage in talking with friends, talking on the phone. What they have to engage in or allocate their attention to is walking, because it takes so much attentional capacity. So we can then ask the question, we've established that there is a difference in cognitive demand between walking in able-bodied individuals and people who use a prosthesis. The question then becomes for us, can we use an assistive device to influence cognitive load in any way? So I've taken one other orthotics example here because I think it's fun to switch between the two. So this is a study that we did in Denmark and it was a clinical question that came, or a frustration that came from the clinicians in Denmark, that these rings or finger orthoses were not being funded by the government because there was a lack of evidence for their benefit to patients who had hypermobility syndromes. So we started to think, okay, but maybe we could demonstrate differences here using our sort of cortical brain imaging software. So we developed a project, and the aim was to assess cortical brain activity in people with Ehlers-Danlos syndrome with hypermobility. There's of course many different types of Ehlers-Danlos syndrome, when they were using a finger orthosis and when they were not using a finger orthosis. So it's sort of a repeated measures study on the same group of individuals here. We recruited 14 individuals with Ehlers-Danlos syndrome with a diagnosed hypermobility, and we measured their brain activity. And this time they were seated, and we were using tests of hand function. So we had some different types of grips that we were testing, and sort of more precision activities as well. So we had a targeted box and block test, which I think I have a picture shortly that I can show you. Relatively large blocks that people had to move from one side to another. We had an activity where they had to lift a jug of water and pour it into cups up to a line on a cup. We had a writing task, which there is a standardized writing task in English. We had to translate it into Danish, and make sure we had it validated in Danish, but we figured that out in the end. So they had to write standardized phrases. And then we had a task where they had to pick up coins from a table and put them into a purse. We randomized all the order of testing. So some started with finger orthoses on and some started with finger orthoses off, but everyone did all of the tests. We also measured timed performance on the tests. These are standardized, validated tests. So we measured timed performance on those as well. Oh, here we go. There's the box and block test. So they have to lift blocks from one side to another, pouring water, standardized writing test, and picking up coins from a table. So we had a bunch of individuals here. The mean age of the participants was 39 years, and all had used their finger orthoses for more than 6 months. Here you see the results of the timed test. So standardized tests, performance on the standardized tests. And no, now I've said splint because we call them finger splints, but no finger orthosis is the blue, and the orange is with the finger orthosis. And right across the board on every test, we saw a significant improvement in performance when these individuals were wearing their finger orthoses. So just there we have evidence that we can say, okay, this has large effects on the individuals when they're wearing their orthosis. At the same time, we were measuring cortical brain activity. So I'm presenting the data in a slightly different way here. What you see on the y-axis is concentration of oxygenated hemoglobin, averaged for the group, and time in seconds in the bottom as they're performing the task. And so what we see here, the green is when this group had no orthosis on, the average of everyone, and the blue is when they have orthosis on. So what we see here is that there is a significant decrease in cortical brain activity while they're performing the task when they're using the finger orthosis. And this article is also published. I think it's published in Prosthetics and Orthotics International, if anyone's interested. And I also think that we published this open access, so anyone can have access to it. We try and always publish open access nowadays. The second task is picking up the coins, and here the red is no orthosis and the orange is orthosis. So we're seeing the same pattern here that there is a decrease in cortical brain activity, and this is on the non-dominant hand, so it's probably a slightly harder task when they're performing it with the non-dominant hand, and maybe a reason why we're seeing large differences. Here's the writing task. So the lighter colors, the light green and the lighter red pink color, are the orthosis conditions. And here we don't see any huge differences, which surprised me a little bit, because when you look at the individual's writing, you see that the fingers are flexing or hyperextending a terrible lot. So no huge significant differences to report there, and the same with the box and block test. So it's more the precision tasks like picking up coins where we started to see a difference here. The results weren't, I mean, if what you're hoping to see is these huge differences. We saw some differences in cortical brain activity. We certainly saw differences in task performance, but they weren't as profound as I expected them to be here. And I think it's interesting to reflect upon why that might be. One thing that I've thought about with this group is that they reported a lot of pain. And I wonder if pain is also affecting attentional capacity. So they're thinking about pain as they perform an activity as well, and that's also adding. And once you've maxed out, I'm not going to see it with my cortical brain measurements. They would, once they're maxed out, they're maxed out. So you don't see any increases in that. So it will be interesting to look at that a little bit deeper, I think, and see if we can correlate changes with how much pain someone is experiencing. And well, I've also been looking into, we should also be able to measure pain centers as well. I know that there's some studies with using this technology that do that as well. Okay, so what about the design of devices? We've said that with these finger orthoses, we saw some differences in cortical brain activity when using the orthosis, and that was a device versus no device. But what about if we change the design of a device? Can we then see differences in cognitive load? And that's essentially what we did in this study with the transfemoral amputees that I mentioned earlier. We had one group that had microprocessor controlled knees, one group that had mechanical knees. And these two groups, we tried to have them as similar as possible. In the 6-minute walk test, there was no difference between these two groups, is important to mention, as well as in the temporospatial data, there was no difference. But what you see here, and you can look from, this is the sort of pre-test period from 0 until 10 is an average test period here. And what we see is that our controls is our able-bodied individuals. So very little cognitive demand here. So this is oxygenated, concentration of oxygenated hemoglobin. Next, we have our microprocessor control group, and then we have our non-microprocessor control group. And we have significant differences here between our two groups. So what this is suggesting to us is that the microprocessor controlled knee group had less cognitive demand when walking as compared to the non-microprocessor control group. So really interesting results. What I think becomes even more interesting is to reflect on the fact that our temporospatial data showed no difference between these two groups. So what this suggests to me is that when we are in a clinical environment observing someone walk, and what we look at is temporospatial data, we look at timing, and I'm not going to suggest that we looked at this in great detail, but what it suggests is that where we don't see differences, and certainly where we don't measure differences in temporospatial data, there are significant differences in cortical brain activity. So the attentional demand is greater without the microprocessor controlled knee. And I think that's really interesting. So what does it mean? It means that people with physical disabilities are more likely to use cognitive resources when they're performing specific tasks that are challenging for that particular condition. Of course, it's going to be condition specific. We also know that assistive technologies can be used to reduce the need for cognitive resources, and this has potential benefits for reducing falls. has potential benefits for participating in different types of activities. So lots of different benefits there. And we also know that the design of devices has the potential to influence cognitive load. And I think there is a whole ocean of research we could do here with different designs of prosthetic and orthotic devices to try and look at, well, can we optimize them in some way using this technology? I'm not suggesting that it's the only way we should optimize, absolutely not, but it's one option that we have. So clinically, what might this mean for the average prosthetist orthotist working in a clinical environment? Well, I would suggest that we need to start to recognize that the demands a disability might place on cognition. So we know that it's going to have an effect, and start to think about how it might affect someone's daily life activities. The other clinical implication here is that we may see cognitive changes in cognitive load before we see them in temporospatial parameters or kinematics. So this suggests that in a clinical environment, we should be using tools to assess cognitive demand. Now, not everyone has access to brain imaging technology, but we'd certainly have access to dual tasking options. And there are many different types of dual tasks out there. So this is also something I've been thinking about a lot. What is the perfect dual task to perform? And does it matter which dual task you choose? And I think it does. What I haven't sort of presented today is we have another study where we looked at dual tasking on prosthesis users, and we'd showed a difference on one dual task but not another. And we can classify dual tasks in terms of motor dual tasks. So a motor dual task might be carrying a tray and holding it, balancing so that a glass of water doesn't fall over. That would be a classic motor dual task. But we also have cognitive dual tasks. So if anyone's familiar with the Stroop test, for example, this counting backwards in threes is another good example of a cognitive dual task. And what we're not quite sure yet is what the effect of choice of dual task might have on cognitive load, because it's probably using different parts of the brain. And there has been a little bit of work done in this area to suggest that the type of dual task does matter. But I'm afraid I can't give many more tips than that. What I suspect is that if we are interested in performing a motor activity, if it's gait, for example, and we want to provoke that, if we want to look at the effects of cognitive load, then maybe a motor dual task might be more interesting. If the patient's greatest interest is to be able to walk and talk and look for traffic and these very cognitive things, maybe we do a cognitive dual task. There's also examples where you have one of each, so sort of a blended type of a dual task as well. But I think it's a really interesting area that requires some exploration there. So what should we do more? What's missing here, and what could we start to look into? One thing that we've just finished data collection, we're just processing the data now, is looking at patients who have had an osseointegration versus patients fitted with a socket and activities there. I'm sorry, I can't give you the results to that because we haven't finished processing those. I think AFOs is also a really interesting area to think about in terms of cognitive demand. I think tuning AFOs is really interesting. I'm not sure that if FNIRs would be sensitive enough to pick it up, but it would be really fun to try. Also to look at AFO design and flexibilities of AFO design to see if we see any differences there. Then, of course, we have lots of FNIRs activity at our university now where we're branching out into other areas. So the driving study that I talked to you about, we're looking at elderly female drivers who I suspect it's a very similar case in the UK, and that elderly women tend to stop driving when they retire, and it's usually the male in the family that drives. And then if they lose their partner, then they are left at home with no form of transport because they're too scared to drive again. So there's a program over here where they're training elderly drivers, elderly female drivers to get back out on the road. And we've been using FNIRS to look at them pre-intervention and post-intervention. It's really interesting to see differences in different activities they perform on the road. So roundabouts are quite challenging, and backing a car makes their cortical brain activity explode. So it's very interesting. And then I think we're also interested in the child group that we look at, to look at children in classroom settings. And I'm particularly interested in this idea of if we can, sitting in children who have disabilities, if we can improve the situation for them sitting in a classroom so that they don't have to concentrate on postural stability, can we change this idea of participation, that they take in more information from the classroom and they can be more active in a classroom setting? So it's also something we're interested in looking at outside of well, that one I think is very related to the orthotics side of things. So I think I have pretty much sped through my presentation this evening, but we have lots of time for questions and reflections and ideas of things that you think we should focus on in the future. And I'm very happy to answer questions and listen to your thoughts.
Thank you so much, Nerrolyn, for a fantastic lecture. What we're going to do is we're going to have a word from Duncan, and then we'll move into Q&As. So just need to unmute Duncan.
Oh, wait a minute. I think I've done it.
That's it now? Yeah, thank you.
There we are. Hey, thank you, Professor. That was really interesting. And I must admit my attention lasted the 45 minutes. The one thing that is very interesting is that I can't speak worldwide, but certainly within the UK, is that we have challenges with P&O prescription due to waiting lists and other COVID challenges. By the time patients come and are assessed and undertake maybe initial assessments before treatment starts, it greatly affects their opinion of the centres they're actually being treated in. Another major challenge we find is that many prosthetists and orthotists become the property of the patient in so much that they like to have the same practitioner all the time, and that builds up the relationship. The number of visits that patients have and the location and the costs and all the hassle, I think, before the patient even interacts in an environment like this, it greatly influences the level of happiness. And that perhaps is my question, is that I was thinking, I wonder if we could measure the happiness of the patient with the opinions given or the device suggested or the actual outcome of the device in their everyday living. So can you measure happiness?
Yeah, really good question, Duncan. And something related to something else we do. So I'll touch upon that in a second. But in terms of cortical brain activity, I think we could. So we can, the issue with this functional near-infrared spectroscopy is that we measure it up to about 3 centimeters down into the brain. So we don't go any deeper than that. So if we can identify happiness, where that center will be in the brain, then yes, we would be able to do that. I think we're working with some AI experts here. I think it could be kind of interesting to use an AI expert to look at, okay, where are we seeing these explosions of activity in the brain? The trick is then to translate it to something else. Is it happiness, or is it mum just walked in the room? So it's sort of, I think it's really difficult. And the same with attention. I mean, what we're saying here is that what we think we're measuring is how much you have to think when you walk, but what we could really be measuring is, wow, that girl that just walked down the corridor looks amazing. So it could be that they're focusing their attention on something else, because that we don't see what they're thinking about. Unfortunately, we can't pull out of our data, but we see that they're thinking about something. And we obviously try to control for noises and activities around the individual so that we do this in a room. But I mean, you even see, and we always make sure when we do the gait activities, we'll explain everything, and then we do at least one trial first where we measure it, and we discard that because people are usually a little bit nervous to start with, and so you see these spikes in activity. But it's really interesting, Duncan, and it's related to something else we're doing that I just have to touch upon, because we just submitted another article for publication, which was a qualitative study here in Sweden looking at sort of daily life, or daily life of prosthesis users. And one interesting finding from that was that we have users here in Sweden. We're divided in regions of Sweden. That's where you get your service, is where your house is, the region where your house is. And we have examples in that qualitative study of patients that buy a house in another region, or if they move to another region, they'll buy an apartment in the region they were originally in, where their prosthetist is, so that they can maintain contact with the clinician that they like.
Very good.
Well, thank you very much. That was very enthusiastic and passionate about your topic. It's really great to see. So I'm just going to share a little slide just to explain, because some people might not really be aware of how to ask questions on this type of webinar. So we would ask you to just, if you move your mouse over the screen, your little bar at the bottom of the screen will come up, and there's different icons there. There's a raise hand. If you raise your hand, we can unlock your microphone to be able to ask the question. And there are quite a few questions in the Q&A, which is the chat. But it would be quite nice to hear you, especially for the event. It's a very exciting and unique event. And so we'd love to be able to hear from you. So if you're looking at these little icons here, then you'll be able to ask questions in that way. So I can see that there are some hands up, so I'll just stop sharing for now. And there was a question. The first question in the chat box was from Gemma. So I'm just going to click on "You're allowed to talk," Gemma, and that should open your microphone.
Hi, yeah, can you hear me now? I should be unmuted.
Yeah, that's lovely.
Yeah, I was just really interested. It's such an interesting talk, but I wanted to know if you compared the healthy control group versus the transfemoral group and their cognitive load at rest as well as movement.
Yeah, really good question, Gemma, and easy to answer here. This is kind of like measuring muscle activity with EMG. So you need a baseline. So what we're measuring is relative difference in cortical brain activity from a baseline measurement. So everyone gets measured at baseline when they're sitting still and quiet for a 30-second period. And that becomes our baseline measure. So it's like EMG in that we know that we can't just measure my muscle activity to Sandy's muscle activity, because maybe I use some sort of cream on my legs in the morning, and it's going to affect muscle. It's going to affect the conductance of the electrode. It's the same. The heads are exactly the same. It's going to be different. So we always have to have a baseline measurement. So we can't really measure at rest differences between these groups, but we can measure relative differences, which makes it easier to compare between the groups. I hope that answers your question.
Yeah, I want to know what your thoughts are with, with brain function, and, if people have had trauma or if they have neurodivergence, would that be affecting the results that you see? For example, if someone's in trauma and they're not actively in their prefrontal cortex, would that affect your measurements?
Also an incredibly good question. So there's been a few different studies on this. What we know is that ADHD has been studied extensively, and we certainly know that we see differences there. We see less activity in the frontal cortex in that group, so we know that that affects it. There's been quite a lot of studies done on people who have had stroke, but nothing P&O related. So we see differences there as well. What we did in our test was that we made sure we did a mini mental health test with everyone, just to look at were there any sort of obvious cognitive problems in our group, to try and make sure that that was controlled for. But I suspect, yes, there are going to be differences. But then there's also some interesting studies looking at people with profound disabilities who are non-verbal, for example, that have used FNIRS to try and look at communication and response to different activities. I have one doctoral student in South Africa that's just about to start looking at those types of interventions for children with really profound disabilities who are non-verbal, and can we use FNIRS as a means of identifying activities maybe that they like. This is a bit like your question, Duncan, happiness, but we'll see where we land there.
Oh, brilliant, thank you.
Thank you so much, Gemma. I'm going to ask Shloak, Manan, Meta now, if you would like to ask your question that is in the chat box. Thank you, Shloak.
Hi, can you hear me?
You're lovely. Yes, thank you.
Hi, thanks so much, Nerrolyn. It's a really interesting talk. I actually had the same question as Gemma, but I think just further on that, what I could ask is, I know you said you mentioned that you measured people at stress and use that to as the baseline, but could you use it in order to normalize this? Could you use a task that isn't dependent or impaired by a disability, and see whether this could explain some variance between groups?
Yes, I think you could. This idea of what to do when someone's measuring a baseline is also kind of interesting. So people have tried different things. There's just the normal sitting still or staring at a dot on the wall, but some people have standardized. So get the person to count to 20, for example. So it's something very easy for them to do. So you could find any other task, as long as we know that it's something that people can do relatively easily. I actually think it's probably better, to be honest, because people aren't quite so stressed doing something. When someone says sit still and don't think, what do you do? So it's counting has been used before. I think you could find, depending on the person's disability, I think you could find something else to use as a baseline, which would be interesting.
Yeah, and second question. So I'm actually really interested in sensory feedback for lower limb prosthetics. That's my PhD. And one of the things I was looking at is to see if there's a difference in proprioception or sensory feedback, and whether that would affect cognitive load while walking. And how easy is it? Have you tried to measure other variables opposed to say MPK versus non-MPK that might also be contributing to the variance that you see?
Yes, we've had probes over sort of motor cortex, sensory cortex, and frontal cortex. So we've seen differences in motor cortex, frontal cortex, or sensory functions in the brain. If you think about the structure of the brain, hands are pretty easy because they're, if you think about homunculus man, they're sort of quite superficial. When you start to get down to the legs, then you start to go down deep into the crevice. And I think it's a little bit, will be harder to pick up motor and sensory activity because it's sort of deeper into the brain. But it's certainly, you could do it with hands relatively easily, I think.
Is that why maybe you use...
I think, can we move to another question, Shloak? That was great, thank you.
You're welcome to send me an email.
Thank you.
That's lovely, thank you so much. So now I would like to ask, I can see that we've got Madison with your hand up, so I'll just see if your mic will open. Madison, we've got a few questions here. Nerrolyn, I hope that's okay. We're still running on, we'll probably run over a bit.
Hiya, is that on?
That's lovely, Madison. Yeah, really loud and clear.
Great. I just want to say thank you. That was really, really interesting. And I wanted to ask whether the link between cortical brain activity or attention allocation and fatigue has been investigated. I think a lot of patients do report fatigue, whether it's because of like a byproduct of their condition or whether it's due to having to think more and be more careful and things like that. And I think it would be interesting to see whether there is a potential to reduce fatigue with the design of devices similar to brain activity.
Yeah, it's I haven't seen anything, Madison, that looks specifically at fatigue. I mean, it would be relatively easy to induce fatigue and test attentional demand, but I'm not sure that you could use cortical brain activity as a variable of fatigue. I'm not sure where you find it, to be honest. You would have to see which area of the brain is activated. But the other way around, you could certainly fatigue someone and see what happens over the period of fatigue, because you can measure for quite long periods of time.
Thank you.
Thank you. That was great. Thank you. And Amy, would you like to come on for your question, which I see is also in the chat box? That's great.
Hello, can you hear me?
Yes, thank you, Amy.
Yeah, so it's more of a comment really than a question, and thank you. I've really enjoyed this evening's talk. So when we are working with our NHS MPK patients, we get our occupational therapist involved in the assessment, and she does an outcome measure called AMPS. And it was quite expensive for us to put her on the training, but it absolutely has been worthwhile for these patients. And what we found is that, as you said, that we're not seeing much significant change in the patient's temporospatial typical physio outcome measures between their mechanical limbs and then their MPKs at the end of the trial and then ongoing annual reviews. But we do see significant changes in the AMPS, which measures both motor and process, and they have to choose a task to carry out, for example, ironing a shirt or washing a window or making a sandwich. So as far as we're aware, and it's quite a small network of OTs in the UK working in prosthetic centres, we're the only centre that the OTs are involved in MPK work. So it fits really nicely in with what you were saying.
Yeah, I think fantastic. Anything that measures these, I mean, it's about, that's the whole point of what we're doing, isn't it? That people are participating in activities that they want to participate in. So any way that we can encourage that, I think, is fantastic.
Oh, that was great. Thank you. I think I did a mute too quickly there, Amy. Sorry, I'm jumping on those buttons. We've got another question here from Helen Smith, and that's going to be audio as well. So Helen, I've opened your mic up.
Can you hear me now?
That's lovely, Helen. Thank you.
Okay, thank you. Just going back to some of the earlier questions, I'm a psychologist, and I'm loving the fact that the early questions were all about psychology, not just cognitive. Nice, holistic. Great talk. Thank you for that. I'm wondering a bit about patients walking up and down in fitting rooms, feeling very self-conscious, feeling embarrassed about the way they look, about what they're wearing, and some of them perhaps feeling quite self-critical, you know, getting self-sabotaging thoughts. This is big in compassion-focused therapy at the moment, and I wonder if that's another cognitive load for some of them.
I'm sure it is, Helen. This is also goes back to that qualitative study we did as well, because it's the same thing. What we saw in that qualitative study, we interviewed established prosthesis users, but essentially that most of them, and of course there's variation, people describe this period of acceptance. And I think this first period is where they want to be discreet. They don't want people to see them. They're embarrassed. And I think that affects a terrible lot of things, cognitive load, but also other things that you, Helen, know way better than I do. But after that period of acceptance, it was really interesting, because that's where they started to throw away their cosmesis, and they very happy to go out, and all of a sudden you're proud of your prosthesis, and it was better just to show everyone, so they stopped looking at why I was why I had gait deviations anyway. So I think it's an interesting area to explore, an underexplored area too, Helen.
Thank you.
Thanks, Helen. So now we've still got quite a few questions. So we've got another 3 questions, and also Paul's got his hand up. So I'll pass on to Paul and then go to the questions in the questions and answers. And I think that's all our questions. I think we've wrung you out, Nerrolyn, of all your thoughts. So I'll put Paul on the mic. Hi there, Paul.
Hi, can you hear me?
Yes,
yeah.
Thank you.
Hi, Nerrolyn. I'm delighted we got you in the end. I may have shared this story before with Nerrolyn, but I was fortunate to have been asked into a research group where they were looking at fatigue in people with balance problems and the effect of AFOs. And initially they were talking about physical fatigue, but once the group started talking, without prompt, they all said it was the mental fatigue that got them. The balance was so bad that if they were walking across an open room and somebody stopped them and talked to them, they couldn't cope. They had to go and sit down and excuse themselves. And as far as participation is concerned, it was massive. It would be fantastic to see your instrumentation on that kind of group, because I think that the difference was huge for the patients, reporting the difference between wearing an AFO and not wearing an AFO, and their ability to participate in social functions where, you know, just walking and then being stopped to talk to people was incredible. So I'd love to see that bit of work done.
Yeah, I think we've talked about this before, Paul, as well, but I think that it's really interesting when our clients talk about fatigue, that they do talk about cognitive fatigue. And there's some really, really interesting research coming from people with hearing impairments, and and looking at sort of brain imaging studies. And what they've shown is people with long-term hearing impairments are at a much higher risk of like Alzheimer's and different types of cognitive impairments. And there's this big discussion at the moment about why is that the case? Is it the case because there's a developmental brain issue, or is it because of lack of participation and stimulation? So it's really interesting to think, or that they've had to listen so hard for so many years that you have this increased cognitive load over a long, long period of time, and what's that doing? But it's research that I'm not deeply involved in. So, but I think it's an interesting area to think about what happens when you have to think so much for such a long period of time.
Thank you very much for that question, Paul. That was a great answer. Thank you, Nerrolyn. I also wondered about falls prevention and raising awareness on that we should be doing all the time with family and friends, not to distract people, and all of the things related to that, which is an everyday task, really. We've got 3 questions in the Q&A section, and I'll read those out for those of you that might be on audio. One's a little double question snuck in there, so it might be 4 really. And there's a couple from anonymous attendees which are absolutely amazing questions, so I'd really like to go through them. We have a question from Babak Beigi. Thank you very much for your great, interesting presentation. And the first part of the question is, how many probes did you use in different studies? And are they fixed in number in the frontal lobe, or is it subject to each case or study?
It varies a lot on the research. We use 16 probes, and the most important thing is the distance between the probes, because the infrared light is going in and bouncing back. So there has to be a distance of 3 centimeters between probes. But there are studies that have used versions with just 1 or 2 probes, if you really can hone in on the area of the brain you want, which I'm skeptical if you can really do that that well. But we put on 16 probes, and then we define what we call a region of interest, which is the area where we think the dorsolateral prefrontal cortex is, or the literature suggests that we should be finding it. Okay. But there are systems that use less probes.
And the second question from Babak is, Is there a correlation between the attention capacity and dual tasking with gender, male, female, or female, male, according to your results and experience within the previous studies?
It's not something I've looked at, to be honest, and so I really do not know, and I haven't seen anything that has compared males and females either. So I'm afraid I can't help you on that one. I have the data if someone wants to process it.
Thank you. And this is really interesting. I've often wondered about which dual task to use, especially when one participant in a group may struggle, especially specifically with numbers and reading in a cognitive dual task. How have you found this in your participants, and has this affected your results, or does this average out?
Very good question. I agree that people get, especially count backwards in threes, people get stressed out. So are you inducing cognitive load by getting them to do a secondary task, or by stressing them out, which also increases cognitive load? But there are other tests that you can do. The Stroop test, if anyone's familiar with the Stroop test, it's this one where you have like colors, and it will say red, but it's written in green, and then it'll say yellow, but it's written in blue, and you have to say the color, not the word. It's not possible to do when someone's walking, but there is an oral Stroop test, so they can have it in an earphone from a telephone and do an oral Stroop test, which is easier, or it's not supposed to be easy, but it doesn't require numbers or reading, which could be useful.
Thank you. And our final question of the evening: have you looked into congenital limb absence patients' performance in relation to their cognitive load?
Not yet, but we have Lottie Hermansson, if anyone is familiar with Lottie in Örebro here, who is an occupational therapist that does lots of research in with myoelectric arm prostheses. Lottie and I have got some money to start to look at training in upper limb prostheses and to start to compare these, but we haven't started yet, but watch this space.
Thank you so much. I think that was really, really brave of you, answering every question. So thank you so much, Nerrolyn. And I've really, really enjoyed tonight. And I really like to thank the Orthotic Education and Training Trust for making this happen. And I'd like to hand over to Duncan for our closing words for the evening.
Thank you, Sandy. It's been a lovely evening, to be quite honest with you, and especially because although we are an Orthotic Education Training Trust, we are very conscious that we interact with our prosthetic colleagues, and I felt the subject here was pertinent to both specialties, and the more we can produce the interaction, especially with so many joint practitioners nowadays, the better it is. I think this has been a very unique evening, a very rewarding one, and I hope that it may be part A of future presentations from you, Nerrolyn. Thank you very much for your time and your expertise.
Thank you, and good night, everybody. Thank you so much. Thank you, Duncan, and thank you, Nerrolyn, and thank you, Krista. Good night, everybody.
Thanks, everyone.